Good night, sleep tight. Don't let the bed bugs bite. Hopefully, that will give an insight to today's presentation. The outline of the presentation would be I will discuss a clinical case with history, examination, and investigations. Then we'll come to a diagnosis and discuss the details of the disease. And I'm hoping to touch a bit about the physiology of sleep, the clinical impact due to lack of sleep, and the sleep disorders in adults. The clinical presentation would be a 50-year-old lady with type 2 diabetes and hypothyroidism, and she presents to the clinic with increased fatiguability and lethargy for a duration of 4 months. She complains of feeling tired and unrefreshed in the morning. Given this scenario, what do you think? What are the possible causes for this presentation? Hello?
Yes, Primali.
Hello?
Yeah, we can hear you. I think that
Yes.
the first possible one is always obstructive sleep apnea.
Yes.
Otherwise, other possibilities are the functional sleep disorders,
Yes.
anxiety, any medications.
Yes.
Um,
Yes. Yes. Yes, I think Triyamaya mentioned a lot of them. The possible causes would be multifactorial actually. It can be due to poor sleep hygiene, simply, or it might be because of thyroid diseases, chronic kidney disease, and it might even be because of comorbid insomnia, restless leg syndrome. Then, as Aya said, it might be apnea or comorbid insomnia with sleep apnea, nocturnal panic attacks, cramps, depressive disorders. All of this can give rise to this sort of presentation. So the important negatives in this case would be she did not have symptoms suggestive of thyroid disease, and there were no anemic symptoms such as shortness of breath on exertion or any palpitations or lightheadedness. She had no depressive features, and the PHQ-9 score was 4, and there were no symptoms of chronic kidney disease such as nausea, itching, leg cramps, and there was nothing to suggest vascular claudication like rest pain, and there were no awakenings with apneic episodes, loud snoring, morning headaches, mouth breathing. Those things were not there in this patient. And she was compliant with her oral hypoglycemics and levothyroxine, and she was not on any other medications. She has reached menopause when she was 45 years of age. She has had slight hot flushes, but no disturbance to sleep whatsoever since until now. So the important positives would be this patient complains of leg movements which are rather uncomfortable while she's sitting down or lying down in periods of inactivity, and this sort of movements get worsened at the evening and night, and she feels unrefreshed and is easily fatigable during the day. The daytime functions were affected, and she had trouble initiating and maintaining sleep, but there was nothing to suggest nocturnal panic attacks such as excessive sweating or reflux, and there was no use of alcohol and caffeine. But however, importantly, she smokes one cigarette before bed, and she scrolls the phone until she falls asleep. Her sister also has these uncomfortable leg movements when in periods of inactivity, and the famous eyes. She thinks she has a malignancy. She's concerned because her daytime functions were affected, and the expectation was to make these symptoms go away. So with that, I think that it is time to subjectively take a sleep history in this patient, because there are things to suggest she's having a sleep disorder. So during taking a sleep history, we have to assess the primary complaint. We have to discuss about the pre-sleep conditions, the sleep-wake schedule, nocturnal symptoms, daytime functions, then anything like fatigue, sleepiness, mood disturbances, quality of life, how is it affecting the bed partner, and so on. So taking a sleep history is quite extensive. I've tried to do that in this. So she has a proper sleep-wake schedule. She sleeps in a good, conducive environment to sleep. She lives alone. She has been living alone for 1 year, and the total sleep time is 4 hours. She's sleep is disturbed 3 times per week. Approximately, and nighttime awakenings are present but no nocturia. She has a habit of clock watching at night, and the patient complains of leg movements, as I said earlier, and there's nothing like hardening of legs, and these leg movements are relieved or reduced on the days she exercises. She's anxious about not getting enough sleep, and she relates this to a probable malignancy. There were no other phobias. So after subjectively assessing the patient's sleep history, Epworth Sleepiness Scale is a way to objectively assess excessive sleepiness. So it is the score is given out of 24, and this lady had a score of 10. So when the score is more than 10, it is rather suggestive that this lady has excessive sleepiness. During the examination, she did not have any features of anemia and no hypothyroid features. She looked exhausted. The body weight was 59. There were no features of chronic hypoxia like finger clubbing or cyanosis. There was no acromegaly, no increased neck circumference. The peripheral pulses were present, no ischemic ulcers, no sensory impairment. The rest of the examination is unremarkable, no joint pains, no neurological deficit, and the Mallam-Party score was class 1. So with these things, what do you think? What are the investigations you would like to do in this patient? If no one's sleeping, hello? Hello? Hello, can you hear me, by the way?
Yes, we can hear you.
Yes,
What is some
what
other?
are the... Yes. Being in the primary care, simple investigations we would like to do, Anna?
Full blood count.
Yes. Yeah.
You
We
mentioned.
have to do some... Yes?
A full blood count you mentioned, no? Hemoglobin normal,
Yes.
thyroid function, and that also you mentioned already.
Yeah, those are the basic investigations because we have to rule out any thyroid problems, any anemia or any chronic kidney disease. So these investigations, all of them were within the normal range. So given this scenario and the investigations, what would be the likely diagnosis? Yes, yeah. The likely diagnosis is the complete diagnosis is restless leg syndrome with comorbid insomnia. Comorbid insomnia is when this insomnia occurs in conjunction with another medical or psychiatric condition. Like in this lady, this insomnia is precipitated by restless leg syndrome. So restless leg syndrome, let's talk about this a bit. Another heavy name for it would be Willis egg bomb disease. It's a sleep-related movement disorder. It's a waxing and waning disease, which is more significant in the evening. And we say the pathophysiology is not yet clear. It is due to alterations in neurotransmitters in the brain. Mainly dopaminergic transmission is reduced. There is a primary restless leg syndrome that is because of genetic factors. It can be either autosomal dominant or autosomal recessive with the carrier state. So as I said, the patient will come up with things like tingling, creeping, soreness, discomfort of legs. But otherwise, if the patient might not come with these symptoms at all, they might come with reduced sleepiness, which is causing easy fatigability, like in this lady. So secondary RLS can be precipitated by risk factors like iron deficiency, chronic kidney disease, pregnancy, multiple sclerosis can precipitate the secondary RLS. So there is the ICSD criteria for RLS, restless leg syndrome. So all these 5 things should be present to say that it is restless leg syndrome. So these things were actually present in this lady's history, lady's history. So there was an urge to move legs, the unpleasant sensation was there, and it was worsened during periods of inactivity, and also it is relieved by exercise, as she said, and at the evenings it is worsened, and any other thing like myalgia, leg cramps, habitual foot tapping cannot explain the features this lady is having. So there's something called chronic RLS and intermittent RLS. And the importance of knowing about this thing is that the daytime functions of these people are actually affected. So restless leg syndrome, there are drugs that can worsen the symptoms of restless leg syndrome: alcohol, caffeine, antidepressants, antipsychotics, metoclopramide, diphenhydramine. So the differentials, we have to see what are the other neurological disorders that gives rise to urge to move. Akathisia is one. In akathisia, the discomfort affects the whole body, but here it is only the legs. Then there is something called isolated leg syndrome. And then there are, as I went through in the earlier history, it might be because of nocturnal leg cramps, arthritis, vascular claudication. There might be a pain disorder component as well. Then there are other sleep-related disorders like periodic limb movement syndrome and hypnic jerks, which this patient did not have. So when it comes to primary restless leg syndrome, which is because of genetic reasons, because this lady's sister also has the same things, the medications do not help much. It is the home care tips like maintaining a healthy sleep hygiene, exercise, pneumatic compression, taking hot baths, trying massage. So all these things are the things that will actually help rather than medications. But having said that, medications are there available, especially dopaminergic drugs, because there's a reduction in dopaminergic transmission in this disease. So carbidopa, levodopa, pramipexole, ropinirole can all be used, but for a short course of time, because the other side effects can occur because of dopaminergic drugs. Also, benzodiazepines, opioids, anticonvulsants we can use for a short period of time. Like in this lady, we gave a short course, 2-week course of pregabalin, and iron therapy and treating any underlying causes are important as well. So a bit about sleep physiology, which is very complex. We have a fine balance between being awake and being asleep. So being awake is done mainly by the brainstem, where you have the reticular activating system. It will be secreting neurotransmitters, norepinephrine, histamine, and they go act on the cerebral cortex, histamine, orexin, acetylcholine, and then that maintains the wakefulness. Sleepiness, that comes from the hypothalamus. The ventral lateral preoptic area of the hypothalamus will be secreting a lot of GABA, and there's adenosine which plays a part. So they will be making sleep promoting system is that. So it is a fine balance, as I said before. The circadian drive and homeostatic drive keeps you awake. And essentially, since we are diurnal animals, around 9 p.m. the melatonin levels rise and we fall asleep. So apart from this neurophysiological system, what is important is psychological and behavioral factors are very important when it comes to sleep. So when it comes to sleep therapy, like in insomnia, we address these psychological and behavioral factors. So this is a hypnogram. Since 1/3 of the humans' lives are spent during being asleep, the sleep cycles occur, 4 to 6 sleep cycles occur during one night. And there's something called the REM sleep and the non-REM sleep. REM sleep is where you get the vivid dreaming, the nightmares. And in the non-REM sleep, there are 3 stages. And in N3 is where wound reparation, bone healing, wound healing, all that happens in N3. So that is important when we discuss sleep disorders. So in brief, the physiological changes that happens in non-REM and REM sleep. So this is by the International National Sleep Foundation. So when we are young, we need a lot of sleep. And when we grow old, the requirement of sleep actually reduces. So a healthy young person will have a longer REM, whereas a young older person will have a shorter REM. That is the difference between the old and young persons. So, sorry. Sleep deprivation effects. What are the effects? This was done by the John Hopkins University in 2022. So the ghrelin hormone levels will rise and the leptin hormone levels will come down, and there will be an increased craving for sweety and salty and starchy food, which will give rise to obesity, diabetes, hypertension, reduced immunity. The natural killer cells will not function well, and that will give rise to a 36% increase in colorectal cancer, by the way. And also, it is during the sleep, the unnecessary information in the brain is deleted and the necessary information is processed. When that doesn't happen, there's a 33% increase in dementia, and the brain will age 3 to 5 years faster than the normal age. And there can be brain problems like depression, irritability, anxiety. Those things can happen. The academic professional performance is affected. Road traffic accidents can occur. So all of these are side effects of sleep deprivation. So that is why it is important. This is the ICSD-3 classification, which is rather tedious. I'm just touching upon the restless leg syndrome we have already discussed about, and insomnia, and the other things in brief. So what is insomnia? It is, as I said, it is a problem with initiating or maintaining sleep, and it causes significant distress to daytime functioning. And the thing is, when we talk about insomnia, the diagnostic criteria is that given the adequate circumstances and opportunity, the patient does not sleep. This is important that we differentiate insomnia from insufficient sleep syndrome, which is kind of common in the nowadays hectic world. Some people have insufficient sleep syndrome because they are not given the adequate circumstances and opportunity to sleep. So that is different from insomnia. So this lady had adequate circumstances to sleep, and she had quite a lot of opportunity to sleep, but she could not sleep. So that is insomnia. So insomnia is quite common. This research was again done in USA. 50% of the population had insomnia, but only 1/3 of the patients came to their primary care physicians. And out of that, only 5% actually told about insomnia. The other people actually talked about different things like fatigability and various other symptoms. So this is the ICSD classification of insomnia. And in insomnia, the thing is there's a 3P model, and there's something called the Insomnia Severity Index, which helps us to get an objective assessment about how severe the insomnia is. And this 3P model is everybody has predisposing factors, but on top of that, if there are perpetuating and precipitating events, if it reaches more than a threshold, that person will get insomnia. So the precipitating events can be severe physical injury, divorce, death, menopause, shift work, and the perpetuating factors can be watching TV while falling asleep and worrying about sleep loss and those things. So chronic insomnia can be because of multifactorial things. It can be medical conditions from pregnancy, malignancy to neurological conditions. And then medical conditions, of course, there can be heart failure, then things like hypothyroidism. So all that can cause chronic insomnia. Psychiatric conditions, depression, anxiety, panic attacks, neurological conditions are there. Then medications like beta blockers, central nervous stimulants, depressants, all of this can cause chronic insomnia. So the chronic insomnia is what we are worried about, because the duration is more than 3 months, because almost all of us have experienced transient insomnia and acute insomnia, which can easily be corrected by sleep hygiene problems. Chronic insomnia goes on for a long time, more than 3 months. So this is from Up to Date. When you have chronic insomnia with comorbidities, assessing the symptom, where the problem is, whether it is at the onset, maintenance, or awakening. According to that, the patient will come up with symptoms, and we can ask about legs, whether the legs bother you, whether you snore, or do you feel down, anything to do with depression and social issues as well. So moving on to the sleep hygiene guidelines, we have to have a regular bedtime and a regular bed rise time, and avoiding daytime napping, limiting caffeine, limiting alcohol, avoiding nicotine, like in this lady who was smoking a cigarette, keeping the environment quiet and dark and clean without bed bugs or mites, and also no bedroom clocks, no smartphone scrolling, and avoiding heavy meals. All these things, and also exercise will help in a conducive sleep. So this is actually a 2-week sleep diary. It is for a duration of 2 weeks. That also helps us to assess the sleep disorder the patient is having, whether things like coffee, cola, tea, or any medicine or any alcohol is affecting this patient's sleep. We can objectively assess through a sleep diary. So insomnia therapy, as the American Academy of Sleep Medicine mentions, insomnia therapy instructions are quite important than the pharmacological management. So there are a lot of insomnia therapies that you can easily find on internet. So starting from cognitive behavioral therapy, with that stimulus control, relaxation techniques, sleep restriction, sleep hygiene education, we can all do that as insomnia therapy. So these are certain drugs we can use. The first ones are the Z drugs, benzodiazepine receptor agonists. Out of that, ezopiclone is supposed to be very effective because it acts on the GABA alpha subunit. So there are things like that, and orexin receptor antagonists. All these things are there, but most of these patients are adults, so we have to titrate the side effects as well when we are giving these drugs. Also with benzodiazepines, if we give them for a longer time, there can be something called rebound insomnia, and also they can get addicted to this benzodiazepines. So we have to use them rationally and for a short time. So treatment of comorbid insomnia is, this is a graph which we used in this lady. We optimized her environment. We advised on stopping nicotine and scrolling the phone, and we addressed the restless leg syndrome, and we gave her a short course of pregabalin as well. And we controlled, so this is the pie chart, the graph or the table we can use when we are treating things like comorbid insomnia. A bit about other sleep-related movement disorders. We talked about RLS. So PLMD is periodic limb movement disorder. It is repetitive flexing or twitching of the limbs, and the history comes from the bed partner, because this is a diagnosis that is essentially done by polysomnography. So bruxism is another thing. There's involuntary clenching and grinding of teeth, which can have a significant impact on teeth. Anxiolytics will help bruxism. So central disorders of hypersomnolence, the opposite of insomnia. So where the patient is excessively sleepy. So narcolepsy is one where the patient is excessively sleepy at daytime. So there can be two types of narcolepsy. Type 1 where there's insufficient orexin, which is, as I mentioned earlier, keeps us awake, a neurotransmitter. So in narcolepsy type 1, the symptoms are severe where the patient can get cataplexy, that is sleep paralysis, and hypnagogic and hypnopompic hallucinations. Hallucinations while the patient is going to sleep and when the patient is going to rise, respectively. So narcolepsy type 2 is less severe, and this is a diagnosis that is made by using polysomnography, and on top of that, mean sleep latency tests and multiple sleep latency tests should be done. So these are cases for the neurologist. So when we get these patients, it is better that we assess and send to the neurologist. Having said that, excessive sleepiness can occur because of encephalopathy, thalamic strokes, Parkinson's disease, multiple sclerosis, schizophrenia. Then also medications like narcotic drugs can give rise to hypersomnolence. And there's something called Klein-Levin syndrome, which is extremely rare. It's a waxing and waning disease. Young males are usually affected with mood, psychiatric, and social disturbances. So an insufficient sleep syndrome itself can cause hypersomnolence. Then moving on to circadian rhythm sleep-wake disorders, that is, their biological clock has gone wrong. So it might be because of a chaotic sleep pattern, like an irregular sleep-wake rhythm disorder. Sometimes there are sleep-wake phase disorders when it is delayed, the patient wakes up late. So they go to sleep around 1 a.m. in the morning and wakes up at 10 a.m. in the morning. The advanced cycle is the patient goes to sleep at 6 p.m. in the afternoon and wakes up at 2 a.m. in the morning, which is not good for the patient's day-to-day functions. And some people have a biological clock that is more than 24 hours, that is non-24-hour sleep-wake rhythm disorder. Then there can be multiple man-made problems like shift work and jet lag, where when you travel through states, the time difference can cause sleep-wake disorders. Parasomnias, in brief, are unusual behaviors, vocalizations that can occur during sleep. It can be either non-REM related, where in the non-REM related, they can have sleepwalking. This is common in kids, and REM related, where they can have nightmares and sleep paralysis, recurrent isolated sleep paralysis. So it's a very wide subject. So sleep-related breathing disorders are common and grossly undiagnosed. Obstructive sleep apnea is one where it is a mechanical problem because there's partial or complete obstruction of the upper airway. The stop band criteria would be more than 5, and there will be around 15 apneic episodes per hour. So, and it responds to CPAP therapy, whereas in central sleep apnea, the problem is in the respiratory center. So it will not respond to CPAP therapy. So sleep-related hypoventilation disorders, that is because of hypoventilation, the carbon dioxide levels in the blood will go up, but it doesn't stay elevated for a longer period like in obstructive sleep apnea. Then there's hypoxemia in sleep, and that cannot be explained by any other respiratory or breathing disorder. We categorize as sleep-related hypoxemia disorder. So these breathing disorders are usually, when we cannot manage up to a level, it is referred to the respiratory physicians. So referral to a sleep specialist in a country where we do not have sleep specialists, these behavioral problems, circadian rhythm disturbances, excessive sleepiness can be actually referred to the neurologist, and the apnea problems can be referred to the respiratory physician, and severe insomnia that is not responsive to basic interventions, we can again refer to the neurologist. These are my references, and this is a polysomnograph, and thank you. I'm grateful for Lalantha Madam's feedback and advice. She helped me a lot with this presentation and gave a lot of important advice. Any questions? Hello? Hello, can you hear me?
Of course, they can hear you. They will ask questions now. I think you have some questions because, like one thing I would like to highlight, according to her slides, she showed a pie chart. So how common insomnia is, though your ultimate take-home message is, you should ask about the sleep each and every consultation, especially the patient with chronic diseases or whatever. Irrespective whether they are young or old, you should ask about the sleep. It's important. Then only, otherwise, she's told like only 3% come and tell about their sleep. They don't get medicine. They are a little bit like they don't think that it is important to talk with the doctor. Yeah, then Pamodi, of course, Primali, just go through the chat box. There's a question.
Yes, madam. Hypothyroidism, how can it cause sleep disorders is the question. Yes, hypothyroidism.
It's again a theory thing, a huge theory in that. Okay, right. Okay, if you can. So, okay, fine, you can answer, or else we can go to the...
Yes, madam. Frequent apneas can occur in patients with hypothyroidism, and because of increased drowsiness, they can have apneic episodes. I am not sure how this apnea happens, but they can have, they are already drowsy because of lack of thyroxine, and there can be a weakness in the respiratory muscle function because of the lack of thyroxine, and it can also cause hoarseness of voice, swelling of the tongue. So I think these things can cause apnea in these patients, resulting in insomnia, and even OSA is a possibility, a risk factor when it comes to hypothyroidism. Madam?
The answer is multifactorial. So not only
Yes,
just
madam.
one. It's multifactorial. There are a lot of things like structural changes, functional changes, and molecules. Like there are few, like lot of things. So each and every, that's why it's a very theory part, like long discussion about that. But anyway, if you see a patient with hypothyroidism, those are the things you should look for. Okay, fine. If you know the theory, it's easy for you to take the history and, get come into the diagnosis. But, it's just not only one reason. There are a lot of reasons for those people to get either OSA or the sleepy disorders. Anyway, Primali, it's very wonderful and, huge sort of lot of theory and nice presentation. And, you nicely, not only the slides, I saw only the slides at the beginning, but the way you present is wonderful. That's very nice, very clear. But I think if you slow down a little bit, it is easy for the others to understand. There are a lot of theory part in between. If the others need any sort of clarification, because I think a little bit the speed is a little bit too much. Because of that, there may be some areas where it's not clear as like we expect from the that is what ideally we expect from the crowd. It should be very clear to them, and then only they can understand the whole presentation. If you think that it is there are some sort of clear areas, you can ask from Primali, so then she can I think do it in few sentences again. If you need any clarifications, you can ask.
I'm thankful for Madam's feedback as well. Madam helped a lot in making this presentation. Anything I can clarify if needed? Hello?
There's another thing in the chat box, I suppose. Just go through that.
That was about the hypothyroidism, madam.
Is Supun there? Because Supun's, I was waiting for Supun because Supun's research is regarding this, I think, sleep disorder. Sleepish or something like that. I can, if I'm not mistaken, because I think I have, yeah. I gave the feedback for this thing, for the protocol. I'm not sure whether he finished it or not, but it's better if she participates. It's not there, he's not there. Yeah, he's not there. Anyway, I don't like the participation is very poor because there are 3 batches plus the senior registrars. I don't think that senior registrar's job is over. So they are the people who should participate for these things and give their ideas. As not only that, they are still, we are learning every day. There are a lot of things we have to update our knowledge. So the SSRs don't think that they complete everything. They pass the message. They should participate for those things because they get a lot from this Friday discussions. When they are registrars, now they are SRs. That does not mean their responsibility is over, the duty is over. They have to participate and they have to give their opinions and their sort of whatever the way their queries, how it useful for them as a SR. All these things, I know. So you have to show your interest, otherwise no point of like wasting our time. But anyway, I'm very proud of you all, Primali, so it is very big hours of reading. Anybody cannot do this type of a presentation without having a good, hours of, I think you had sleepless nights. I'm pretty sure about that. Because
Yes.
I gave a task. I told you within 20, few hours you have to complete. So she did it.
Yes.
Yeah, but she got the time. She did it. So it's good that.
One question, madam,
yeah.
what
Not
about
me. I'm not the speaker. Us from your
yeah, Primali, yes. I'm question to Primali, madam. That is, what about this sleep, the somnambulism and the sleep
Yes.
terrors? Which category it will be?
Somnambulance is sleepwalking. It is
Yes.
quite common in children, and we categorize that as a parasomnia. So that is, yes, parasomnia. And also, since the patient is sleepwalking, it
Yeah.
occurs in the non-REM part of the sleep. Because in the REM part, there's muscle atonia. It doesn't occur in the REM part. It occurs in the non-REM part of the sleep. And that is quite debilitating to the child, because in the non-REM part is where bone growth, maturation occurs. So it is quite common in children. That is all I know.
So do you think that they have the symptoms of sleep deprivation because of that?
Yes, sleep deprivation because of it. Actually,
it should be Primali. It should be, because it's a non-REM part, because there was a slide in that, I suppose. Parasomnia.
Yes.
Yes,
There's a slide, because not only that, what she mentioned was there's very, very huge thing in that. When you see that, when you hear the thing, or not only just a statement, what are the most important things? Is the baby's sleepwalking? What are the things of course, it's not just the sleepwalking. What are the other things you have to look for? So she mentioned it. What are the other things?
About school performance and those things?
Yeah, Primali, could you please repeat it again for the other audience? What are the things?
Bone growth and bone growth and maturation of gaining weight and brain development. All that happens in N3 part of the non-REM sleep.
Yeah. So what are the things you should look for now?
Whether the baby's growth
height
is happening,
height
is,
and the
weight. Yes, madam.
Yes,
no, just I wanted to clarify whether they have the
cognition, height, everything, right? So those are the things. That is how you have to get from, if somebody says the answer, okay, then you have to understand these are the things I have to look for the persons who are having sort of sleepwalking, the babies, because it's in the non-REM part.
Okay.
Okay, then. I think there was a slide, I suppose.
Yes,
if I'm not mistaken, because I went through all these things. Seniors, do you have any questions?
Madam, actually, I wanted to ask a bit about the differences of nightmare and night terror.
Primali, you have any idea?
Yes, there is a significant difference between nightmare and night terrors, because nightmares occur in the REM part of the sleep. So, whereas night terrors are things that happens in the non-REM part of the sleep. So, when you wake up after having a nightmare, you will remember it. When you wake up with a night terror, you will not remember anything. That is the difference, because nightmares occur in the REM part where the brain is actually active, as I said. But in night terrors, the brain is inactive. The patient will have a night terror and they will be using their arms and legs especially, and they will not remember it when they wake up.
Okay. is there any gender difference between that? Because I
Okay.
remember once I read somewhere night terrors are more in boys, and there is no difference in the girls or boys regarding nightmares. But I have to recheck that.
We
I have
actually don't know about that.
yeah, I think we can read now. Thank you.
How do you know the patient had night terror or nightmare? Because in night terror, they cannot remember. How do you know as clinicians?
If the parents are trying to comfort the child, it is not possible, because even if the child is, the parents are trying to wake up the child wouldn't wake up.
No, the thing is, if you have some, because though the person they cannot remember with the terror, what will happen? What will happen to the muscles? They do think that they have contract. So, Primali, could you please put that particular slide? It's all the things are there in the slide. I think it will be down. Not that. Parasomnias. Yeah, this is the one. This is the one. So that is the here. So now you can understand. So then night terrors, it's in the non-REM related one. So with that, what will happen? So they have all the side of the people, the outsiders will observe their sleep pattern. Maybe they contract their muscles. They think that, but still when they wake up the child, they don't know what's that. But in REM part, the baby or the whoever, they get up and told, okay, I had a bad dream. But they don't have this. But they have like physically they move with that terror. Because it's terror, they feel the terror and they accordingly they react. Because
And
that,
yeah.
huh?
No, madam, I wanted to add something later.
Yeah, of course, yeah.
No, madam, this is not related to sleep, but I thought it's important to remember that in children, it's sometimes nocturnal epilepsies also can occur during non-REM sleep, especially also benign Tollendek epilepsy, and also it's really important to exclude those things because
Exactly. That is very important to exclude those two from that. It's good. There's a good, it's good that your contribution is very good that in that. Yeah, this is how, when you have this type of a presentation, you try to relate to your clinical scenarios. When you see patients, this is how I had to differentiate it from this and, all these things. That is why we are doing that type of presentations.
Excuse me, Dr. Sindhupa, if it's so, we have to do EEG and get it sorted out, no,
yeah,
whether this
but
is due to
yes,
night
of course.
terror or epilepsy.
Epilepsy, but in epilepsy, most of the time the bedwetting would be there, and sometimes, especially in frontal lobe epilepsy, children may complain about headache later, and also tongue bites and those things would be there.
Yeah, if witness is there, we can ask.
Witness is also there, and if there is any suspicion, we can refer the child and get an EEG.
Yeah. Thank you. I also now only I got it.
This is actually a different topic, this child-related sleep disorders. There is a wide variety of them. I have actually not touched it.
Anyway, thank you so
But
much.
it's a good eye-opening, so that anybody can, if they know these are the things we should learn, and you cannot talk everything. right? But you have to give some sort of stimulus for them to read, and then you use these things when it comes to the clinical practice. Because you cannot finish everything in 1 hour or maybe 1.5 hours, you cannot do. But you have to show this is the depth of the issue, or the depth of the the topic. That is what you did very nicely. Good.
Thank you, madam. Shall we, madam, shall we?
Yeah, shall we?
end?
Because others, I think they have to learn, because, okay, fine. Anyway, others, of course, few of these people actually left. Now,